Principal del Centro de Educación y Capacitación del Departamento de Cirugía e Instituto de Educación en Ciencias Médicas y de la Salud, IMHSE, y asesor del decano en la Facultad de Medicina de Lincolnshire de la Universidad de Hong Kong. Bienvenido y vamos a darle un fuerte aplauso. Welcome.
Right, okay. I think we're getting late. I'm standing between your tea break and my presentation. First of all, I have to thank the organizers for inviting me all the way from Hong Kong. 36 hours flight time, but being a surgeon, I'm used to be on call for 48 hours, so I can be. I have taken the liberty of using Google Translate to translate into Spanish. If things are right, give credit to me. If things are wrong, blame the Google. So that's right.
Professor, I need you to speak really, really close into the microphone for the interpretation.
It's not the technology, it's the technique. Okay, that's right.
Professor.
Which one? Okay.
Do you want to hold it in your hand?
I think hold it in my hand.
Yeah. Okay, very close
That's
to your mouth, please.
Okay. I want you to read this. This is a new intern in your hospital. Been seen by a patient. Doctor, I'm scared. This is my first time to have a procedure. And the intern said, I know how you feel. This is my first time too. Okay. And this is the definition of incompetent doctor. Okay. So that's now, when we look at my presentation is mainly focused on undergraduate education, but it has got implication on the postgraduate education, particularly residency training. Now, if you look at when you join medical school yourself and you ask your parents, what are your expectations about me? Your parents will say, be a good doctor. That's all. They wouldn't describe what a good doctor means, but they'll say good doctor. If you ask the patient, what are your expectations from me? He will say, be kind and caring. Be kind and caring. And Eric touched upon professionalism on that. And the patient's friends, relatives, their expectations will be an expert. Be an expert. And therefore, medical institutions, our expectation has to be a competent professional. Okay. So I think when we talk about competency-based education, we have to talk about what are the expectations people have, the patient has, patient's family has. Okay. And that's what we have to look at. I'm not used to looking at the screen because I usually like to look at the computer and then, well, there's a quotation. You don't go through everything because if you do, you really got microscopic eyes. Okay. I have no objection for doctors to become rich, but not by exploitation. Okay. I think the medical profession, sometimes we were created for our own extinction. And sometimes, places like Hong Kong, when I meet my young doctors, residents, and I say to them, it's not about the money. Okay. Is it about professionalism? And I won't read for others. So the question is, why we change or modify curriculum and its structure? Why we need to? Because people will say that I graduated 40 years ago and I'm quite successful now. I was graduated 30 years ago, I'm successful now. Why you want to change? But there are many things. Societal expectations have changed. We looked at what people expect, patient expecting from us. So society changed. There's advent of information technology. There's the best evidence in medical education. There's a BB. I think Madalena is somewhere in the house. She's the president. Okay, and the BB is doing a good job. But the important thing in medical education we have to see is that first 2 years when we used to teach basic sciences, we used to teach the facts. Krebs cycle, 14 branches of maxillary artery. But students didn't realize what it is for we're learning. So therefore, the basic science has to be taught in clinical context. And that's the bottom line now when it comes to education. So therefore, the curriculum planning and design, what it makes in practice, traditional based curriculum, which we have gone most of us down, it was really able to achieve. We gave the education and we expected graduates to achieve something. Outcome-based and competency-based are synonymous, but there's a some fraction difference between that. If you look at the outcome-based, it's able to show, if you think about Mirror's pyramid. But the competency is able to do and perform. Okay, so the competency-based curriculum is about able to do and perform, because now there's always a debate about traditional curriculum was time-based and competency-based is not necessarily time-based. I don't think that debate is any more valid. You can use time-based and competency-based combined, particularly in residency training. Now, doctor knows the best, so does the patient. Okay. In my hernia clinic, when the patient comes to me, they'll ask me, what kind of surgery are you going to do? Laparoscopy or open? I just listen to the patient. I say, give me a tutorial for 10 minutes, what you know. And they'll say, are you going to do pre-peritoneal approach or intraperitoneal approach? Are you going to do open under regional anesthetic or general anesthetic? So with the information technology, with the Dr. Google, internet, there's a lot of information people have now. So doctor knows the best, so does the patient. And we have to think about that in competency-based curriculum. So if you have to put in a nutshell, what are the three pillars of competence? One is professionalism, practice-based skills, and patient safety. Patient safety is becoming paramount nowadays in terms of pillar of competence. There's no point saying that I did the operation, God save the patient. Those days are gone now. So the competence, one of the meeting in AMI and also World Journal of Surgery asked me to define the competence. It actually is a state of sufficiently capable and properly qualified to do something at a level is accepted. Because we know that medical practice can change every 5 years. New medications can come. We use CT scan, MRIs, now PET scan came, there may be something more coming in future. So you have to make sure the element of lifelong learning means that they are capable of doing something which is accepted, and that's about competence. Now professionalism, now if you go on a Google or a Bing or anything, and you just put professionalism, there will be something like 30,000 entries about professionalism. And professionalism in any field will have different. But if you look at what it really means, it's really a set of values and standards. That's the first thing. In medical profession, we need to achieve, maintain, and exhibit. When we are undergraduate students, they have to achieve that. They have to maintain during the residency and exhibit when they see the patient. And in terms of competence, care, compassion, high moral values, honesty, integrity, and dedication. These are the keywords about the professionals. So in competency-based curriculum, we have to remind our residents, our students, this is all about the professionalism, okay, not just learning of the facts. And we have to remind ourselves the WHO definition. Health is a state of complete physical, mental, and social well-being, not merely absence of disease or infirmity. In fact, WHO definition has an element of competency-based education and the guidance. Now there's a perception, and I think Eric mentioned about this in different years. Tomorrow's health professionals are taught by today's teachers with yesterday's curriculum. What happens is once we're stuck with yesterday's curriculum and then hoping we're training tomorrow's doctors, that's not going to work. I think we have to change with the time as it goes on. Now, if you look at the directory of world medical schools, now there are so many medical schools are coming. Country like Belize, I hope there's nobody, is anybody from Belize? Belize has got a population of 200,000 and they've got 6 medical schools. Medical school has become industry now. It's become industry. And what is happening, unfortunately, is that the graduates we are producing, the residents we are producing, we are giving them the exam and they are only fit to pass exams. Competency-based curriculum assessment is about, is he or she fit to practice? Because many of the degrees nowadays are given as just passing the exams, but not fitness to practice. And then the workplace assessment was mentioned. Now there are enough studies which shows how the clinicians learn and manage. The first thing is about script memory or pattern recognition. If you look at these pictures of American presidents, when you look at Obama's picture, you know immediately it's Obama. Nowadays, when you look at Trump, you know immediately it's Trump. But if you look at the first or second or third, sometimes you don't know. What is meant by pattern recognition is that something you have seen, you have presented, you have managed, you remember, you got script memory. Okay, you see the patient with appendicitis, you know that immediately we see the next one, you have a pattern recognition. Amount of exposure, experience, and most important is analytic skills. Okay, even if your residents may have everything else, but they may lack analytic skills. One of our top graduates in Hong Kong, who has a gold medal in surgery, if I ask the question, what is the cause of abdominal pain in this patient? He will come out with 16 differential diagnoses because he was gold medalist. He knows the 16, including porphyria. But analytic skills is about, out of those 16, which is appropriate in terms of management of that patient. So the essential competence is, if you use the mnemonic, is the 4H. Particularly in any field, in medicine, it's about hand. We touch the patient for physical examination, doing procedures. We have to use our judgment with head, with the brain. We have heart for communication, and we have to think about his and her patient safety. So this is the 4H logarithm about essential competencies. Now, changing of the curriculum. The fact of life is, who wants change? Everybody's hand goes up. And then you say, who wants to change? Then everybody's hand is down. Okay. And whenever we talk about any curriculum change, faculty is always excited about when it comes to PBL, workplace assessment, CBL, PBL. They say, oh, how wonderful idea. And then you ask, would you like to change yourself? No, somebody else can do it. Competency-based curriculum is we have to all. Now, in Hong Kong, we did a study of our interns. We follow all our interns every 3 months because they were 12 months of internship. And we found out what are the source of complications and death care. Lack of prevention. Okay. Something they should have done, they hadn't done in time. Our interns is supposed to attend the patient within 5 minutes if called, within 5 minutes. And that 5 minutes is not metric, not 100 seconds a minute, it's 60 seconds a minute. Intern must be there. Second on call must be there in 15 minutes. There was a problem about intern being called and not being in data. Too many investigations were asked, or asked for the investigation, not been seen. Communication problem. If you look at the medical legal records, 60% of the complaints are because of either lack of communication or miscommunication or no communication. Drug medication, prescription practice. We said there's something we can do, and here comes the competency-based curriculum. We have to make sure there should be no complication or zero tolerance to the complication. Now, I think this was mentioned about competency-based framework by United States, Canada, okay. In People's Republic of China, we took an initiative now, what we think is important in for competency framework, particularly for both undergraduate and residency training. And we thought patient care should be the center. Patient care should be the center. Whatever we do, patient care center. Communication, professionalism, teaching, lifelong learning, quality, technology, knowledge, clinical reasoning. This is the framework for competency-based curriculum. Patient care in the center. And we are trying to adopt it for both higher and basic residency training. So what approach we took in Hong Kong about competency achieving curriculum? we thought about undergraduate and postgraduate as a continuum. It's not like undergraduate medication is some separate from the higher. And we looked at competency progression from the day somebody is admitted to medical school, and the day he or she becomes a specialist, there has to be competency progression. And that could be from the basic and generic training, higher training, developing expertise, and continuing professional development. So we have to follow that as a continuum of the semi-competition. We don't. Now, changing face of learning environment. Okay. Now, when you talk about, we are sitting like this now, but when you talk about the students nowadays, they're very computer literate, information technology literate. Have you ever seen when you give a lecture how the students behave? They are either there on mobile phone or the computers, okay, and we're just looking at them. They probably see you, but they're not looking at you. They can hear you, but they're not listening to you. They know what is going on, but they don't want to understand. Okay? So it's a changing environment. Now we have taken what I call it restaurant approach. Okay. Wherein there's the round tables, okay, and the students, in wherever form you use, PBL, CBL, TBL, whatever it is. Okay, you can be very interactive and have changing environment. We live in the digital age. Memorization is outsourced to technology. When we were in the schools, we used to learn by 13 into 226, 13 into 339, we memorize it. But nowadays we don't have to. So it is all outsourced to technology. Only thing you have to remember is your wife's birthday. Okay? That you must memorize. Okay? Don't depend on your computer, okay, technology. Otherwise you are in trouble. Okay? You have to remember 298. Okay? So what can we do? What approach should we take for competency-based curriculum at undergraduate medical faculty or even residency training? There has to be a written document, a syllabus. We have to think about what teaching learning methods you're going to use. And I think Eric talked about assessments, okay? And there has to be